Well, it looks like we have quorum for both, so.
All right, I'll call the May 21st Select Board meeting to order. We are meeting remotely per Governor Baker's orders in relation to COVID-19, where we are allowed to not do certain provisions of the open meeting law. We are allowing remote participation through this Zoom as a webinar. It looks like we have 2 attendees at the moment. And I will turn over to Denise to call her meeting to order, and then I'll take a roll call.
Good morning, everyone. This is the, oh my gosh, who knows dates anymore? This is the 21st. May 21st, thank you. This is the May 21st joint meeting of FinCom with the Select Board, and I call the meeting to order. Thank you, Dawn.
Thanks. I'll take a roll call in the order in which I see you. Jason Bridges.
Here.
Christy Ferrantella.
Here.
Matt Fay. Oh, Matt, can you hear me?
Here, yeah, I got it finally.
Rita Higgins.
Here.
Okay. And we also have on Erica Mooney.
Present.
Libby Gibson.
Here.
Ryan Turbett.
Here.
Roberto Santamaria.
Here.
And Gary Shaw.
Here.
And Denise can do the roll call for her board.
Thank you, Dawn. Again, in the order that I see you. Oh, sorry, my dogs are barking too, so they're both here. Peter Schaefer. Peter, you have to unmute. Hit unmute, Peter, or hit your space bar.
Got it.
Thank you. Chris Klowacki.
I'm here, Madam Chair. Based on the agenda, I'm going to recuse myself from the remainder of the meeting.
Yes, thank you, Chris. Peter McKeehan.
Here.
Jill Veith. Yep. Jill. Still muted, Jill. Okay, we see you waving. You're here. Okay.
I'm here.
Stephen Morey. Oh, thanks, Jill. Stephen Morey. I'm sorry, Stephen, I didn't hear you. Stephen's frozen. We'll go to George Harrington.
Here.
Joanna Roche.
Here.
Stephen, are you unfrozen? We have a quorum in any case. So back to you, Dawn. Thank you.
I also have Alexandria Penta on. Can you hear me?
Thanks. Yep. Hi.
Thank you. Okay, so we are here to discuss a request from the hospital in regard to funding for a couple of different kinds of testing. And maybe Gary wants to give us an overview of the proposal.
Sure, Dawn. Thank you. I'd be happy to. So first, I want to thank everybody for coming together with such short notice. I have to admit, I'm learning here how this whole town process works. I haven't been here that long, but you have been extremely supportive and come together whenever asked. So thank you for this opportunity as well. And if there's a more formal process I need to follow in the future, just let me know it. I'm learning as we go. So I appreciate your patience with this. So as we know, we have COVID. That's a name that I would like to forget someday, but it's not going away soon, as we all know. And in working with the community, the board, and the Department of Public Health and the Board of Health, we've been trying to come up with methodologies to get tools in place that allow us to understand the prevalence of COVID here, what it's doing, who it's impacting, and so forth. And we know we have 14 cases. We know we have individuals that are those cases that are actually part of families. We know those families were impacted. So if we did broader testing, we would have larger numbers because obviously those individuals have stayed in homes and recovered and haven't had to have care that was of a higher level need and have not come into the cottage hospital. So testing is one of those things that's been near and dear to everybody's hearts because it's just been limited. And when testing did come out initially, it was thought to be the end all be all. And then I know that across the country, different vendors have not produced results that have been always reliable. So it starts out promising and then it goes backwards and we end up with limited capacity again. The Mass General focus is to make sure the research supports the results that we're getting. MGB is a world-class organization, and they've been very careful in endorsing testing criteria that exist with other providers across the country, simply because they want to make sure it meets their high standards, which are very high. That said, there are a number of companies that have moved forward and feel that they have products that can be made commercially available. We saw that in Martha's Vineyard recently with a company named Quest. And obviously, we're all intrigued, and we look at that capacity and opportunity to think this through and how it could help our island. The reason that I'm involved in this, quite frankly, is because the Department of Public Health came forward and gave the Cottage Hospital a request to help develop a screening plan, a surveillance plan that could be considered reliable and could give us indicators now or anywhere along the way related to what we're seeing in this current round of COVID, or even if we have rounds 2 or anything else in the future, what that could potentially look like. It is typically not the Cottage Hospital's business to do work in the healthcare field that is outside of providing necessary medical care. And so our focus at the Cottage Hospital has always been on emergency visits and being a barometer to the Public Health Department on what we're seeing and helping this community see what we're seeing so that we can together do what we just did, and that's raise an alarm when necessary, and then help the Department of Public Health and the Board of Health navigate what in this case has turned out to be a very, very challenging situation here and across the country. So that said, testing of this variety of non-medically necessary care is not what the Cottage Hospital's mission typically focuses on, but we are part of this community and we are the health resource, and we want to make sure that if there's an option available, we want to talk about it, and we want to talk about plainly, openly, and transparently the challenges or opportunities of bringing any particular type of tool back to the Public Health Department. Talk about that so that we can help make intelligent decisions moving forward that impact all of us in a safe way. So there are 2 things that we've developed, and I believe most of you might have heard that and see some other faces today that on this committee weren't visible on the select board meeting, but might have been dialed in. There's two areas of thought. Let me first say that I can't stress this enough. What we know today about COVID, in 3 days, we're going to see different information. What we know about payers or payments and what communities are eligible for, or healthcare providers are eligible for in doing care and getting reimbursed for it, or meeting medical criteria, which allows for reimbursement, change just about weekly. So we know that the scenarios are evolving through things that we read in the news about philanthropy paying for some testing that a company makes available, or a state paying for something that it makes available, because right now insurers are still analyzing the federal requirements and what the states need from those payers in order to move forward. So all I'm trying to describe is an environment that's highly fluid, highly changing, and yet I don't think that us having availability or knowledge of a particular testing source could be more important at the time, and I wouldn't hold back ever in talking about it just because I'm waiting to see what a state does or a payer does. I think the community needs to know what its options are, and we're certainly here to help drive this discussion. So early on, before we knew that there would be more broad testing available for COVID on the PCR side, we started looking at what would be an opportunity to do a pilot, a study, which would allow us to see a cross-section of our entire community, the island, and how could we study this island to know what's here. We know that we have low numbers, but we know that there are more cases that we've had, that's clear. So we assume that we haven't had a lot of cases, and we assume that if you've had a case, you have some residual immunity, but we don't know that from a research perspective that that's true. We assume it. So what we're trying to do, and Roberto, just step in and correct me if I say anything that's misleading or wrong, we are trying to find tools that allow us to have a barometer of what's going on, kind of how's the weather changing, and then also an opportunity to lean into this and do testing where we could see if there's active virus. So we've come up with two scenarios that are in front of you today. And the first one I'll talk about is serology testing. Serology testing allows us to see antibodies that have been produced at a level that would infer that you've had an infection, and that infection is either ongoing or it is already passed, and you have a typical type of antibody that can be measured that shows that you've had an infection. What we want to do is commission a study which this morning was approved by our Education and Human Research Study Commission or committee here at the Cottage Hospital that would allow us to move forward and collect de-identified blood samples, meaning that the process would be individuals that come to the Cottage Hospital would be asked to review and sign a consent form that indicates that any excess material that is the result of a clinical visit may or may not be used in a research study to further the health and understanding the health needs of a community. If an individual grants that, then we would look at discarded blood samples, being those that have no patient information on it, that would be sampled, and we would be sampling 200 individuals every 2 weeks for 6 months and sending those results to the Broad Institute, which we found has the capacity to run those types of serology studies using a blot type of paper. The process is lengthy to explain, but to get those samples to that site, run those tests, and get those results back. And then each set of 200 that we would be submitting in this pilot study would be turned around to us within 24 to 48 hours. And we would then sit down with the public health department to go over, and our research, the primary investigator, to go over, what does it mean, and how do we use that information to understand where this infection is, and if we need to make recommendations to the Board of Health for any changes that might be needed to impact the community. And so, or to be able to go and do more definitive testing in particular enclaves within the island. So it gives us an opportunity to look at what's here now on a serology side, and then how does this climb through the summer. It includes anyone that would come in the emergency room or our primary care area and have blood drawn. It would include an article in the Enquirer and the Mirror educating the public on this study and what we're hoping to use it for. But it would be throughout the summer for a 6-month period of time into the fall, so we could see current exposure, incidents of previous infection, and then look at how does this emerge in the fall? What does it tell us related to our Nantucket community and our visitors that are here? So to put this together is quite lengthy. I have never put together a research study. I've never been asked to. But because we belong to, as a family hospital, the Mass General Brigham scenario, we've been able to connect with Harvard, MIT, the Mass General, the researchers that do this for a living, and develop a research protocol that makes sense, that can now move on to our internal review board called an IRB, which takes pains to make sure that these studies run according to the way they're written and give us back the types of results and that we're hoping to get. It comprises a large research group. It comprises sampling materials, supplies, and so forth to get this going. So for the Cottage Hospital to have never written one of these before, and within a month's time be able to move this forward to get approval at this level for this community, I just want to tell you that there's a tremendous amount of individuals that you can't see behind me that I'm very proud to say are doing this work, and it's good work. Now to move it forward, we need funding, and the funding for this we would envision would be through a foundation fund that the Cottage Hospital would manage for, obviously, this particular study. And as of this morning, I had to make an adjustment to what I gave the select board last night in the overall budget for the study, in that the Education and Human Resources Committee wanted me to make an adjustment to include a research coordinator. And so I did that, and that's a cost increase of $40,000, we believe, at this point. So that's reflected in the current numbers that I have in front of you on the document. I wanted to make sure you could see, what the pilot project budget would be, the expenses from researching all the way through the community foundation already providing a check for $52,200 towards operations, and so the residual ask that we're trying to get funded through philanthropy and potentially through the town is $261,800. That's a lot of money. It is a lot of money, and yet we understand that the economic fallout that we're facing running blind in this pandemic is much greater than that cost every day. And so my ask in this particular instance for this project is to the town and to give some consideration to fund a portion of this as a show of leadership and commitment with the commitment the Cottage Hospital is making and trying to get this study going. And so I'm not asking you for a specific dollar amount, but I do think that what might be left, if any, out of the town's commitment, if it can so make one, we would focus on specific donors and a specific ask. And the details of that, as this is moving so rapidly, I've yet to been able to get concisely. That's going to require some discussion with my board and with my leaders here. So I'm just wanting to get information out now so that we can look at if we have the benefit of time on our hand with COVID's not giving us that benefit. We would like to get this moving so that we can see what we have. So that's one ask. If I can. Erica or Don, do you want to discuss these separately, or would you like me to describe both of them?
I think both, unless anyone.
Okay. All right. So, so for your reading pleasure, the entire study is listed there with the budget at the end. I just have to comment, I want to be wherever Stephen Murray is. He's got that great background outside. I want to be out there with you, just enjoying a day out in the sun, and we all should be able to enjoy it that way. But that's great social distancing. I commend you for where you sit.
Gary, I'm practicing physical distancing from my children who are making
Yeah, a very wise and great move to give that kind of leadership to your family. So moving into the next topic, and that's PCR testing.
Before you start, we have one public question from Howard.
Yes.
I'm sorry, two questions. One, how are the 200 samples chosen? And two, there will be no known relationship between one group of. Correct. Those are the two questions.
You broke up, but I think what I heard.
First, how are the 200 samples chosen? And then that there will be no relationship between one group of 200 and another. It will be people coming into the hospital, correct?
That's a great question. So we obtain many samples per day, much more than 200 over a 2-week period. They would just be simply chosen randomly. Basically, for the day, be produced and just be picked randomly. Since there's no identifying information on them, it's a random study, and so that would answer that question. What was the next one, Dawn?
And then there would be no relationship between each sampling of 200 because it would be people coming into the hospital randomly selected, correct?
The randomly selected information that would be in the study so it's de-identified as we would collect the provider who actually ordered the sample, so we would know by provider how many of each sample purple top we had. but the information collected is there's no patient name. There would be an age, but the age is not an age specific to, I'm 63, 63 wouldn't be on there. Ages would be from 0 to 10, 10 to 20, 20 to 30, 30 to 40, 50, 60, and so forth. So there's a range. From a date collected, it would be de-identified so that you don't pick a specific date. You pick a week. We don't pick a date, so that there's no ability for us to go back and look at any particular comparison to an individual that did have a study done.
Sorry, can I ask a quick question? My video won't work, so I know it's awkward, but
Sure,
did you say if there's any indication of residency? If there's a permanent residency, so we know if it's a Nantucket or if it's a visitor?
No, we're not collecting that, and that's because it would allow us, that would be an IRB question, but that would potentially allow us to track something back so that we want to be worried that the sample, we want to be completely sure that the sample is totally de-identified. It is obviously blood collected on Nantucket on a particular date range. Roberto?
I think also it's important to catch on that when it comes to that the samples are being taken on down. It takes into consideration the dynamic population. Fact is that person was here. So those are people who are here on those specific days with viral load or no viral load. So it's just important to also see that, the value in that part.
Thank you. Gary, did you want to continue?
Yes, I'd be happy to. Thank you. On the PCR testing, I'm hearing a little bit of background there.
Oh, I thought John Giorgio put his hand up for a second.
I yield the floor.
Sorry, John, you're muted.
Unmute.
There. Oh no, unmute again. You're still mute. Okay.
Can you hear me now?
Yes.
Gary, has the study been approved by the Department of Public Health, and what would be their role?
That's a great question. There's two avenues to go forward with studies. One would be that the Department of Public Health initiates the study, and because it has the authority within a community to initiate a study, it would not have to go to an IRB. At the Mass General, it would essentially populate, as I understand it, the study itself through a state approval and move forward. This community doesn't have the resources to do that type of a study and did not ask us to put together a study for the state locally, so we did not put it into the reference category of a public health study that was initiated by request from the Board of Health to the Public Health Department. The reason that we're taking the study to the IRB is because that is the body within the Mass General that oversees any study to ensure that it's compliant with all national protocols and laws and ethics to ensure that that study is done to the equivalency that a public health study for a town or a state commissioned that way. So we want an equivalency. That's the reason there's a difference in types of study approaches.
Thank you.
My pleasure. I believe I got that right, Roberto. Did I get that right? Yes, I did. Okay. All right.
Yep. Sorry, Gary.
Gary, could you elaborate on the reason for the Boston cohort?
Yes, quite a bit of discussion around that because we know that we are co-located in a state to some large hotspots, but that's considered a reference point that's necessary for a study of this size to give validity to what's occurring in one cohort and what's occurring in another cohort. Without that, it's not felt by the researchers that we would get a correct representation of what's actually going on. All right. Feel free to jump in anytime, but I'll continue moving then. For PCR testing, Polymerase chain reaction testing, PCR, it's kind of a long word. This is a test that actually can find a viral particle, is my understanding, and that viral particle means that you've got the active causative agent of this infection, in this case, COVID-19. Currently, the availability of testing, as you see across the country, is highly variable based on where a community is, where manufacturers might be, availability within the medical systems that might be there. And so here in Massachusetts, we know that there are a number of initiatives that have been underway to test certain parts of a town, or it's been advertised that a town can be tested. I'm hoping that if a town of 50,000 people has an initiative going on, that they can actually achieve the number of tests necessary to do that. In the case of Martha's Vineyard, the Quest CEO and I have had a discussion about what the intent is to support that community. And he has made a commitment within his company to support active PCR testing for that island in a number of phases. And the phases, as I understand it, on their island would replicate what we might consider here. Of course, this would be a public health focus on how we define what phases look like. But the good thing is that they indicate they have the capacity to do PCR testing for the islands, both islands, and they would like us to be able to explore that. That requires a swab, as you probably know, to be inserted all the way back to the end of the throat, the end of the nasopharynx, and then be put into a viral media and then sent to Quest and have those test results come back in 24 hours. In this case, the Cottage Hospital hasn't determined that it would use one company or another. We still have discussions going with a couple that we think might be able to provide testing. But certainly the most visible right now is Quest and what it's been doing to support the vineyard. What we recognize is that in order to find a particle for active surveillance, which is what Roberto had asked me to help put together as a program that can do surveillance, it would require that the health department, with our support, come up with a testing methodology that looks at those at highest risk, those that are employers, so we look at successive waves. You could look at high risk testing, which isn't currently considered to be medically necessitated. So those workers in hotels, those workers on boats, those workers on airplanes, those employees within the town and so forth. As maybe a first option, I'm only suggesting, not trying to put any words in Roberto's mouth, but the test can be expanded then to other, to a broader range very quickly, just by the number of tests that we would have to order for this. To support it, it would require a very large expansion of our drive-through area that we've currently set up for what our mission states, and that's to look at medical necessary care. But we would probably have to expand that most likely to an area outside of the Cottage Hospital, maybe over to the high school. We've looked at that as an option in our surge planning with the town, with Roberto, on how we would do testing if we found that we had a large surge. So we would have to figure that out. Those tests through different companies now have come online. They're self-selected tests if you would like to get them. But we would like to help the town find a way to make them available to the community and to those groups that are identified to do them rapidly. My understanding is that from meeting with different laboratory companies, that we could be doing some of this testing very quickly. And when I say very quickly, probably within a matter of days to a week, once we figure out the logistics and the staffing and how we would get those pieces going. There's several components of this that you have to understand are extremely challenging for a community. Number one, obviously, is the cost. Number two is the logistics and finding the staff to do all of this testing. Number three is once you get the tests back, you have to do something with them. They're going to come back with the results that indicate that something probably needs to happen. And from a Roberto and from a Cottage Hospital perspective, that means we're going to want to know if somebody has identified as a positive, that we can then have the information to be able to isolate here or wherever they happen to be, and then also do contact tracing. So contact tracing in a large community surveillance project is essentially what helps us stop the spread of this infection, that and isolation. And so it gives you not a real time, it doesn't give you a 45-minute turnaround, but it does give you a 24-hour turnaround, weather pending, because we always have the impact of weather here and whether we can get those samples that are collected out on an airplane or we can get them out on a slow boat or a fast boat. So those are some caveats that have to be understood that, as you do this testing, it does take some time to get it back. So we don't have the funding to do PCR testing that's outside of medically necessary. We are testing anyone that comes to the Cottage Hospital, and if they screen and it's a medically necessary test, we're doing that. And the current environment is that as we know, there's no cost to the patient. This testing is voluntary that we're describing, and I'm simply bringing it forward as an option that Roberto asked to have on his plate because it's there, and community members can get that test individually if they go to these laboratories. We're willing to be a collection site. We're willing to be a vessel to put our workforce together with the town and the public health department to make sure that this can work and we can get some testing done. But currently, my suggestion is that and I know I'm probably changing this from what you heard on television last night, because after I said some things I've learned from my chief financial officer and others, how we structure things typically on Nantucket. But I would also suggest that these tests be funded through a philanthropy section, a pot, if you would say, at the Cottage Hospital. Obviously, those donations would be used then to be able to pay for those tests that are considered independent decisions by either employers or individuals to get this done, or the Department of Public Health to encourage individuals to get them done. The tests themselves, we don't know what source we would use, but we would recommend, in order to fund those, that some seed money start, that we could then also work through our philanthropy network to get matched or to grow so that this initiative could start. And so we would ask that the town support establishment of a philanthropy fund at the Cottage Hospital for this initiative as well. And that monies that go into that from the town, if there is seed money that you're willing to put in that, we would go out specifically to donors and ask for a way to continue to have this fund grow so that we continue being able to do that testing. Now, there's two options here that I would just want to throw out there. These tests, we know, are if they're voluntary at this point, they're not medically necessary, and they're not covered in the insurance environment. But we do want people to come in, and if they do meet screening criteria, to let us know that, and so we can test in that environment. These regulations that payers have might change in a week or 2 weeks, and you might say, well, let's wait a week or 2 weeks to see if they change and those tests are covered. You might find that as other states are doing, states have stepped forward to fund these initiatives themselves, knowing that the industry and the insurance environment is somewhat looking towards some guidance on what they're going to be asked to do or expected to do or end up doing. So states have stepped in to say, no, this is too much of a public health need and we're going to fund it. One state comes to mind that's done that recently, but you can Google it and find those areas. You could wait for that to occur as well. But what we're simply doing is putting an option on the table for the Department of Health to consider, the Board of Health to consider, the town, but it would require funding. So what level of funding? It depends on how many people you test. The charge at the Nantucket Hospital that's published through the Mass General is $150 a test. And so do the math on how far that goes, with how many dollars go into philanthropy. But that's where we sit. So I don't have a specific ask to start that fund. Last night I suggested 200,000. That would give us about 900 tests to start out with. And we could go forward trying to match that through philanthropy in different ways. But I would suggest that both funds come through the Cottage Hospital philanthropy environment. So Don, I think that's it. So Roberta, did I miss anything?
Oh.
No.
Thank you. Peter Schaefer has his hand up.
two questions, Gary. Number one is, if you can explain to us the benefit of the research study to the people of Nantucket and the actual people who live here. What are you going to do with the results? And number two is, can't you charge $20 a person for the test to help offset the cost?
Well, if we charge for a non-medically necessary test, there is no reimbursement. Okay, and so we don't have the funding to create an environment for that. The second question is, from the standpoint of results and how we would navigate the use of that, the study clearly shows what we're proposing come out of it, how we would use the information to understand how much viral load is here. We know that if we have a little bit of viral load, that means that we're at high risk for having more infection. If, in fact, we get research that shows there's inferred immunity, it would infer that the more infection that you've had, the less risk you have as a community in having more outbreak in the future. And so we would want to know that, because I think the Public Health Department and the Board of Health would then want to talk to their members in the town about measures that might need to be considered, as we've been asked over and over, how do you use information to make decisions on how you behave as a community? It would help us Yes.
Wouldn't mass testing do the same thing?
Well, mass testing.
If you tested 10,000 people on Nantucket, wouldn't your results give you the same information you're going to get from the research study?
Well, we know that there's a lot of asymptomatic carriers that are on the island, and so PCR testing would give you a considerable amount of knowledge related to active disease. It would not tell you the amount of healed infection that's on the island. And so you could make decisions with PCR testing in one sense, yes. But we believe that the understanding of what is here, so that we know how much prevalence is available, if we know that there's been immunity in future research, that would also help us understand how much PCR testing would be necessary. So they kind of go hand in hand if they're available.
All right. Thank you.
Roberto, I think you should add some clarifying understanding on that.
Can I just say something? I mean, just simply stated, the serology tells us that you did have COVID, and the PCR testing tells you that you do have COVID. I mean, it's, I think, the simplest way to look at it for people to understand it.
Correct.
Correct. And the serology test is looking for a specific protein, whereas the PCR is looking for a DNA marker. So what it does with the serology side is we now know that approximately 80% of people are asymptomatic, so they wouldn't show up to a testing center and they don't meet case definitions of testing. So what a serology study would be able to do is catch those asymptomatic groups. We'd be able to estimate the viral load on the island for any specific population, knowing what our baseline is. The information about this virus keeps changing. We're learning more every day. So even yesterday, there was a paper released from Beth Israel Deaconess saying that, so yesterday you heard me say that, quoting the World Health Organization, the CDC, that even if you have antibodies doesn't mean you're immune. Well, yesterday, as I was saying that, there was a study released saying that they found that there are some antibodies in a rhesus monkey that does provide immunity. So they're hoping that they can be able to push that into a vaccine. So it's one of those things. What we're starting to see is some people who have antibodies are immune. Others who have antibodies are not immune. This would be able to let us estimate what sort of a level of, for lack of a better term, herd immunity we have on the island, and it'll help us shape policy and emergency orders and things like that.
And risk. I mean, it does two things. It helps you navigate how you manage your population, knowledge and actions you take, but it also helps the cottage hospital understand its risk of being overrun. If immunity is low and you have a high outbreak, your medical system could get overwhelmed, as we've seen in other areas.
I think Jill had her hand up.
Yes, can you hear me now?
Yes.
Sorry, I just wanted to know how this would be. I mean, we've seen a study from Boston, and that study said, I think that the serology study was at 10%. Is that right?
That's my understanding, and one of them, yes.
And so at this point where I think what you're saying is we don't test enough, we need more testing, and I understand that. Why would we want to do the study now and not wait a little longer if we have a study to look at that said it's 10% in a community that had a high infection rate? We're a community with a low infection rate. So that's what I'm trying to, or is it just you think not enough people came forward to get tested?
So I believe, so the studies are each crafted to focus on a different particular outcome. And in that case, I remember the number 10%. I didn't read the study, but I would, if I translate that to the island, what I would say is, what I would highly recommend is that we not wait to understand how much of a sitting duck we are. In that if you have a very low level of immunity and you have a large circulating population, how well you social distance, how well you set up your protocols, and how well people behave and adhere to that is going to be very quickly determined as to how many cases you have. What you can do when you have a serology test combined with a PCR test is understand where those focuses are and start to take public health measures to contact, trace, isolate, and so forth, since there's no treatment. So we feel that it's better to make decisions with information than just leading into it blind, especially with the type of community that we have that grows, and it ebbs and flows. And so what's the risk?
Can I just jump in here for a minute to just change it a little bit? One of the things that I wanted to talk about on today's call is, you're asking the towns for funds, and you have, it's different than what you asked for yesterday. So thank you for acknowledging that, Gary. And, you're looking for potentially seed money instead of full funding, which is excellent. Second piece of that is, though, with any funding, with any requests, typically there's time to digest what the numbers are, why the numbers are what they are, to be able to ask questions about it. The town's reserve fund is $500,000. And, if we go back to what yesterday's ask was, this would be and so I would have expected to see more details on the proposal in terms of numbers, how the money's going to be spent, all those kinds of things. And so to get an ask at that magnitude with no documentation and understanding that everybody is full out right now, right? That it's there's swans on the pond where the little legs are going like this, but the swan is going like that. So completely understanding of that. And I would also like to just see some more detail around the financial numbers and the financial implications of this, even if we have to have another emergency meeting tomorrow or the day after, just to make sure that we're doing the right thing fiscally, because I'm just concerned, number one, of using up a good chunk of our reserve fund for this, because who knows what's coming. Number two, numbers change. So whilst we'd like to think these are the numbers, and maybe private donors could jump in with closing the gap, the numbers will change. I mean, the serology study went up $30,000 overnight. So we don't, and I know with studies that if you can't do 100% of the study, that the results then are compromised. And, things like, for example, you said that at NCH, the KPCR test is $150 when it's broadly $100 other places. So, it's understanding overhead and all those kinds of things. I was a CFO before, I get that. And then at the same time, I just think we need a little bit more scrutiny on numbers before the town commits to spending and understanding the urgency of it. So I just wanted to kind of bring that up into the topic, because we could all, I'm fully supportive of doing the right thing to protect the island and to protect the health of the island. There's no question from my side that we should do something. I just want to do it in the most fiscally responsible way, because, as and when this thing moves through, we just want to make sure we don't do something today quickly that might negatively affect the town's finances going forward that would be harder to recover from. So if it's okay that we kind of shift the conversation to that for right now. Not that you guys, if you have questions that you want to go back and ask questions about the study, please go ahead. But I just wanted to bring that up. Thank you.
Peter McGecker.
Good afternoon. My question is specifically to Brian and possibly Libby. With the fact that July brings another fiscal year, which of course we won't be able to have, we assume we're not going to have an ATM prior. And Gary's study is the pilot study is over a 6-month period of time. So it looks to me that the cash burn would overlay 2 years. Can we authorize, I should say, next year's reserve monies towards any of this because it's over that period of time, that 6-month period?
We couldn't authorize any funding from this year out of a budget that hasn't been approved. So if we authorize funding, it's coming out of all of this year, unless we were to have a meeting after the ATM, if we have it, to authorize spending from that budget. And if we don't have ATM, we would have a 1/12 budget, which we would have to submit relatively quickly anyway to get DOR to approve it so we could spend on July 1st. And we'd have to include any funding in that request. But I can't allocate today out of next year's anticipated reserve or anticipated budget because there's no adoption. So we would have anything we did would come from this year's fiscal funds.
Yeah, but just for conversation, it's potential cash flow after an ATM, potentially.
We could, if we had ATM before July 1st, we could certainly have the understanding as we went through that there was going to be coming out of that a budget line item somehow, some way for next year for cash. But I don't want to speak for the town manager's priorities and how to fund next year. That's for her.
Chime in 1 second. Peter, you may possibly not have been involved in the conversations that have been going on for the last week or two about town meeting. The board last night basically agreed to have town meeting on June 25th. So we were talking about this at our meeting last night, and the idea at that point was to seek a transfer from the fiscal 20 reserve fund of, I thought it was either 232,000 or 332,000. It wasn't totally clear. And then I'm sure that it could be revisited in fiscal 21, but we always are very hesitant. FinCom historically been included, as you know, to dole out money out of the reserve fund at the very beginning of the fiscal year because we don't know what's going to happen as we obviously go through the year, particularly now. But the idea yesterday was to seek a transfer from the reserve fund with some of this initial money, at least, that's being talked about.
Okay, so where are we? Do we want another meeting? I'm just trying to understand where people stand on this.
Well, the KPCR, the PCR, or I keep calling it KPCR. I used to work for Siemens Healthcare Diagnostics, Gary, so that's why I keep, as the CFO, by the way. So that had no numbers at all on the document. So I personally would like to see numbers that we can ask questions about, even if it's the back of an envelope thing. But I would like, and I mean, rest of FinCom, please, are you comfortable with putting a number on the table today before we see the documentation?
Well, let me just ask specifically, what I've told you is our charge, and what we don't know is the vendor. And that's on the PCR side. On the study, that is our budget. That was changed by our committee today.
Yeah.
Once approved, that can't be changed unless an amendment goes to the IRB changing it. So I have full confidence in that budget, and those are the numbers. But how much? Just be specific in what detail you would like, and I'm happy to provide anything I can.
Okay. Well, Gary, I would like to see the expected, and maybe this is something that Roberto can do right now off the top of your head, but to say, because Roberto, I have full confidence in all the things that you can do, which is we're going to do 1,000 tests. So there, boom, it's $15,000. Or right, no, it's $150,000. We're going to do 1,000 tests as a minimum on the KPCR side. and there will be no incremental cost besides the cost of the test. And, because it's just the cost of the test on the KPCR time. So that's exactly, how long is a piece of string? How many tests are you going to do? So as long as there's no incremental cost to that, then that's okay. That's clearly the number. That is the number. Okay. Secondly, on the project budget for the serology, I don't think that it's a fully funded from Nantucket because it's not just a Nantucket benefit. So I would be comfortable with personally, not as chair of FinCom, but I personally be comfortable with us contributing a certain number to that, depending on what everybody says. And then the Cottage Hospital and their foundation being able to look to private donors to fund the balance of it. So I do think the town should contribute. It does benefit our residents, our community. Not just the residents, but the community. So that's kind of my thoughts. But I would like to stop talking now and have the rest of FinCom share their thoughts. Stephen?
Yeah, I just want to press on that cost of the PCR test again. Gary, I think I heard you say that the $200,000 would fund 900 tests, which doesn't work out on that.
I don't have a calculator right in front of me. I'm just whatever,
So it's $150 all in. So we take the $200,000 and we divide by 150, and that's the number of tests we're going to be able to run and get results for. Is that right?
I think that's the right way to approach that. Yes.
1,333. Because I always have a calculator. George?
Denise, I just wanted to say that I do believe your approach to this is good for us, and it would be nice to see a little more in the way of numbers on paper so that we can also chew on those over a short period of time. And perhaps another meeting in the very near future is what we should be contemplating. Thank you.
Thank you, George. Joanna, I'm just going to call you by name. Jason, I see you, and let me just run through FinCom and see what they think, and then we'll come back to you. Thanks, Jason. Joanna?
I'm in agreement that we need to have a little more fiscal oversight, but in support.
Thank you. Jill?
I would like to see more information. And I was wondering if somebody knew who funded the study that Mass General did in Boston.
Peter McKeechan. Sorry, Peter Schaefer, you had gone dark for a minute. Peter McKeechan?
Maybe I'm an outlier. I'd rather fund today and move on, but that's just me.
Okay, thank you. Peter Schaefer?
Yeah, is the testing a competitive business that you can go out and get bids from different people? Gary?
To my understanding, these companies set their prices based on market, and we always go out and look for that across the market to see where there is capacity, so they can vary.
And have we gotten prices from other people?
We don't have enough detail today to speak to that specifically, so I would say no, we're just learning who actually has capacity as we're talking now.
Well, based on that, you shouldn't be asking for money yet. If you don't have the answers to the questions on whether you can do it cheaper with somebody else, how do you know how much money you're getting?
Well, as of today, we don't know that we can do it cheaper with anyone else. We know that some companies are talking about having capacity. Today, we know that there is one company, Quest, that has the capacity to do that. So that's the reason for the discussion.
I'm still confused on why you haven't talked to other people.
We're looking across the country constantly, Peter, but we haven't found those yet that have been able to give us what you're asking as an answer. So as soon as we find those, certainly we'll be looking to who has capacity to handle this kind of a study and bring those options forward.
Okay, I go back to my otother question I brought up before. There's no way that you can charge a small fee for the test to help offset the cost, in addition to whatever you're gonna, you're scheduled to $150. If you could charge $30 a person, that would generate a lot of money.
Actually, for a non-medically necessary test, it generates no money because they're not billable. And since they're not billable, we do have testing available for those that have and meet criteria for symptoms, and there's no charge for that currently. What I'm referring to is where there's no funding.
No, I understand that, but can't the potential patient pay that out of their pocket?
Well, they would be paying for a patient billable expense or through a philanthropy expense, as I've discussed, the cost of the test. But the cottage hospital has no money to donate towards that process.
No, maybe I'm ignorant, but about this whole process of how your philanthropy and everything. But all I'm saying is, if you're going and do a test, and the test costs you $150 to do, can't that be offset by a contribution, quote unquote, by the person who's being tested of $20 or $30?
Well, our current contracts agreements don't allow for us to change pricing, outside of what's been established within the system. And so the answer, as I understand it today, is no. But I can get more specific answers, but I don't have that. I don't have a different answer for you right now.
What if you called it an optional contribution?
Well, who's giving the contribution, Peter?
The person who's getting tested.
For the cost of the test, or the charge of the test. So you're suggesting
you can call it whatever you want. I'm just trying to figure out a way to help offset the cost. So if everybody comes in and gets a test, and you say to them, we would love it, and this goes on lots of times for charity. We'd love it if you could make a contribution of $20, but if you can't, fine.
Oh, I think that's a great question. When the test is ordered, if individuals have the ability to pay, we would ask them if they could to do that, so it would offset that cost, certainly. But there would need to be dollars to pay for the test that was done, even though they might be able to offset it with $20. That would certainly help not eat into a contribution fund as fast.
Okay, so we've had Jason had his hand up a while ago. So Jason, first you, and then I'll go to Matt, and then Peter McEachern, and then Stephen. Jason?
Thank you, Madam Chair. I just wanted to know, or at least make sure that if we were to go forward with this and put, whether we fund it all or some portion of it, what the role of Roberto will be. Will he have control, or is it here you go, and then the town doesn't really have any say of anything? I would want to make sure, or at least know what his role would be, and if Roberto had some type of guidance in any of this.
We only see ourselves as a vessel to accommodate the testing. We would want the strategies to be set out by the Board of Health and by the Public Health Department.
Gary and I will be working hand in hand on this one. And of course, one of the things that we've already been talking about, but one of the things that I'd love to see is the raw data, so that we can also do our own analysis on this on top of the analysis that's already being done. Just because it's very hyper-local.
I think hand in hand was an unfortunate analogy, Roberto.
we're physically distance holding onto the same 6.5-foot rod.
Okay, Matt, you had your hand up?
Well, I did. I was going to say that Peter and Gary were kind of, sort of saying two things, sort of from two different directions. And I think that, I think there is a way to have people tested and, ask for donations, and some people would pay all of it. Some people would pay more than all of it. Some people, some employers would give $50 a test, whatever they could give, and the money would go further. I think it's important that we do this, and we do this sooner rather than later. If our incidence of infection is low, then we, I think Gary used the term sitting duck, then we are in a higher level of risk entering the summer with the amount of people coming. It can be quantified. We haven't done that yet, but that can be factored in, and our choices that we make should be making choices that lower that risk, that do the most to keep our economy going, while at the same time lowering the risk to everybody. And and this is a first step toward doing that. So I support all of it, part of it, whatever we have to do. I think it's a low amount of money, and I know it's difficult to find, but compared to the devastation of hitting, we need to go out and surveil right now. We need to be getting out into the community now, not waiting for people who are so sick that they can't, that they have to go to the hospital. We want to be finding out where it is now and taking care of it. The economic catastrophe or devastation, if this thing
puts us in a shelter in place mid-July would make this look like a rounding error. So I hope that we don't putz around with this for a week or two, because we've already done that for 4 weeks. And I'm not meaning that nobody has done anything, because everyone's really busy. I don't mean that as a critique, but this virus has its own timeline, and it's not ours. So,
thank you, Matt. Peter and John, I see you. I'll after Peter. Peter McKeegan.
More a question for Gary or Roberto. What happens if a Myron or a bunch of employers want to get together and do their own, through Quest or through MGH, do their own PCR testing? Could we?
Well, you can't currently do it through the Mass General. We don't have the testing the volume for that. But certainly, if they want to do it through Quest, I would, to the other Peter Schaefer's point on the video, if people have the ability to pay, we want them to pay. I mean, that we would want that to be a step up and help so that you can do the greatest good for the greatest number with what remains in the fund. So yes, and those results would come back to the public health department as well, so we could still look at that information and help the community.
So as an employer, it doesn't make sense for even every employer on the island to fund testing for their team members, for the staff. One would assume that people working at first line of defense at hospitals and firefighters and what have you, I'm sure they've already been tested. I mean, doesn't it make sense that every employer tries to get on top of this and funds at least it funds for their staff?
Well, we think so, and for that, we would ask them to come to our occupational health department for the same testing. But it does make sense, and that's the point of this. If you want to have those questions answered and we can have a source available, then yes.
So, a question, I think we all know the answer. Who's the largest employer on the island?
Well, I've only been here 5 months, but I think it's the town.
Thank you.
Was that a trick question, Peter? Okay. John had his hand up a bit ago, Dawn, and then Stephen, and then I'll come. John.
So just very quickly, listening to a lot of these concerns, and of course they're all very legitimate, I wanted to remind everyone that before the town is going to provide 200, 400, whatever amount of money to fund these tests, there will have to be a grant agreement in place. Brian and I have already had preliminary conversations about that. And so that would be the mechanism, which is a legally binding agreement, where we could ensure that, Roberto, for example, and the Board of Health have oversight of the testing. We could deal with robust reporting from the hospital in terms of what process they use to select the test. Are there any other alternatives? So there's a lot of control the town is going to have in a grant agreement that would be signed by the select board.
And also with the financial side of it too, John?
Meaning what?
Be able to financially track. So all of a sudden, we expected to get meaningful results for 200,000, and guess what? We got to 200,000, and now we still need to spend another 200,000 to get to the results that we were hoping. I'm not saying that's what will happen, Gary. I'm trying to anticipate anything with the speed with which we're trying to do this. I'm trying to anticipate what could go wrong, so we're not surprised later. That's right. All I'm doing.
The grant agreement would have a grant limit.
Okay.
Of 200 or whatever you come up with a provision that if they need additional funding, they can certainly come back to the town and make a request.
Okay. Thank you, John. Dawn and then Stephen.
I'd like to see the town take some leadership here and make a meaningful contribution to this, but to encourage some significant donor contributions. Mm-hmm. So, I'd like for us to do something today, but
I think it makes sense to do something today, provided we get the caveats of the oversight and the controlling, because again, approving numbers quickly on the reserve fund, et cetera, I mean, we got numbers this morning at 10:14 for testing. So that just, the fur on the back of my neck stands up. Stephen?
Question for Gary, and I think also for Roberto. How far does 1,300 tests go? And for Gary, I guess that's a question of how much capacity do you have to actually collect the tests, collect the samples to be tested? And then for Roberto, what's a meaningful sample size? Should we be looking at, from a scientific standpoint, does it make sense to look at group testing or something like that, where we can use a smaller number of tests to get a larger cross-section of the community?
Go ahead, Roberto.
Okay. So to answer the question about testing, usually what you're looking to shoot for is about 10% of the population that you're going to study. If we're going to use a year-round population, we'll say about 17,000. You're going to look at around 1,700 tests. But around 1,000 tests is more than enough, because statistically there's a process called bootstrapping, where you can do randomized sample methodology in order to resample the same data that you have in order to extrapolate that into a larger number. Without getting too technical, bootstrapping is an accepted biostatistician's tool. If we were to look at the two programs separately, there is the serology and the PCR. I think the PCR, correct me if I'm wrong, Gary, PCR is the Quest diagnostic one, right?
That is correct.
Okay. If we were to look at the two separately, the one that's most useful for me is that PCR one. The serology one, because those are people who are actively going to the hospital to get this information, and it is randomly sampled from those blood vials. So what that tells us is that these are people who are presenting there. If you're looking at the PCR Quest diagnostic style, those are people who are self-selecting to go out and test. So you're introducing bias when you look at a self-selection. It's called the selection bias. So the people who are going to actively search out a testing center like the Quest diagnostic one are more likely to be healthy. So you're more likely to skew that number a little bit to the health side, which is why the serology one is a little bit more unbiased for me, because it is it's kind of like a randomized clinical control trial, but it's not really, because we're not assigning cases and controls. We are, in our own case, Boston being a case and a control for us. So we're going to be able to do these types of sampling. So in my opinion, the serology one is, I think we should at least take action on today. The Quest one I do like, and I would love to see action taken on it too. And I want to see both go forward because they're both useful. But if we had to choose, in my opinion, I think serology, but I do love both programs, and I don't want to take away from either of the two, because they're both very valuable data that I can definitely use. And I think, I don't know of another way to say, I guess not hand in hand, but lockstep, as long as we're 6 feet apart, with the hospital to move forward in the same direction.
So the other part of that question was, how much can we test per day? So our drive-through that we currently have set up with the staffing is about 50 a day. If we're going to do, 1,000 people, it's going to take us a little while to get there unless we increase that staff. That's a big expense. So we'd want to do this on an appointment basis, where we're proactive in how we set up a methodology with Roberto, and then decide how rapid we need to move based on what we're seeing for illness or for infection. If we need to make it larger, we can scale it up. We may not be able to scale it up at the site that we're using at the Cottage Hospital. We might have to go to the high school. So we can flex that, Stephen.
And then I don't know who the question's for, but maybe for Roberto. The other part of my question was about group testing, and that may not be a clinical term, but it's something that I've read about, where communities who don't have resources to have a lot of tests to collect samples. So they'll use 5 or 10 samples maybe in the same test, so you can clear a group of people at once. Is that scientifically meaningful, and is that something that we might be able to do?
That's what you're referring to as group testing. That's the bootstrapping that I was talking about. I can quickly draw it out on my whiteboard if that makes it easier.
Don't know if we'll be able to.
Okay. So basically what it is you have your water, your cup here, and it's full of ice. You take out a piece of ice, and that's considered a sample. And then you throw that piece of ice back in, you shake it up, and then you resample from the same bottle. That's called bootstrapping. So you're creating a new re-randomized sample within the same sample data that you have. So it is considered it is scientifically sound, and it is possible to do so. It is last resort. What you would like to do is get as many samples from the population that you want. So let's say we throw, mainly because I'm Hispanic, let's say we throw the Hispanic population out there. We get 150 samples from the white non-Hispanic, and we get 5 from the Hispanic population. That's tough. You can't just resample that population because it's way too small. The variance is way too small there. So we're going to have to possibly push for those last, we'll say it's 200 samples. We'll push for those last 40 samples to be from the Hispanic population so that we can bootstrap. But in a situation where we get 100 from the white non-Hispanic and 25 from the Hispanic population, then we can go back and bootstrap from the 25 samples. Did that make sense, or did I get a little too nerdy on that?
Yeah, no, that's good. Thank you.
Matt, you had your hand up. Matt?
Yeah, just another way to look at it, at least how I look at it, maybe Roberto or Gary can correct me if I'm wrong, but serology isn't sort of to stop an outbreak, it's to understand what the prevalence is in the society. Whereas PCR, if we get out in the community, that has the potential to slow or stop an outbreak. That's more proactive. Is that correct?
Kind of.
It's kind of. Mainly because the like I was mentioning before, the PCR, where it's like a voluntary self-selection, it tends to skew the data to the health conscious. So it may actually hide the real number. It'll be kind of like an underreporting of the cases. So it's still really good. But if we did have PCR coupled with the contact tracing, that could definitely help, mainly because, but we would need to collect data and the information on who it is that sampled. We would need that identifiable sample, not de-identified data, so that if it comes back positive, we can get in contact with the people they've been in contact. And yes, it can stop the outbreak in where it goes and create more of that flattened curve that we're hoping to get. It just a little bit more involved.
So Matt, I think another add-on to build on what Roberto was saying is PCR testing is going to give you a more accurate representation of who's an asymptomatic carrier. Those that aren't showing symptoms that have been tested, and if they show viral particle, well, then that tells you you've got a situation to deal with.
And that was my point. My understanding is that and some of it is outreach. If there's areas that we believe, and populations that we believe are at risk, we can, test them more stringently and target where we need to target. That's sort of my understanding. Whereas the serologies, we can do something about it. There's a name attached. So I just think that, they're both very important.
Okay. Thank you. So my question is now, to Dawn's point earlier of wanting to get something achieved today, from the FinCom's perspective, is there anything out? Who makes this, number one, who makes the motion to spend? I think it has to be FinCom, correct? Because it's to spend the reserve fund. So Brian, Libby, and Dawn are all nodding. This is excellent. So, and I would offer though that the amount comes from select board. No, it doesn't. The amount, well, I would say that the select board and FinCom should be in agreement about the amount.
Yeah.
Not just FinCom saying, okay, we'll give you $25,000 and FinCom goes, yes, goodbye. Right. So
Denise, typically the way this would work is the select board would make a request to the finance committee of a reserve fund transfer in a particular amount.
Thank you, John. So Dawn, I'm going to turn it over to you so you can have that discussion.
Hey, I'm just going to throw an idea out there because I like the general concept of matching grants, and that maybe the town consider contributing half of that outstanding balance, which is, I think, about 130,000. Is that right? Wait, sorry. Let me go back to that.
I mean, for the serology test only?
For both, it would be 430. 430, it's 261 plus 200, so that's 460, 180. So it would be 230, would be half for each. Yeah.
Yeah.
Sorry, I lost my screen. Oh, hang on.
So the two together, Dawn, it's 200,000 for KPCR or up to 200,000. Mm-hmm. And though I did do the math, Gary, based on the 50 tests a day, so it would take you 6 months to do 1,000 people, just on the side. So 261 for the serology, 200 for KPCR, 460 divided in half, 230.
Yeah, I think it'd be like 20 days, probably closer to a month because you have the other needs-based testing. But
oh yeah, of course. I just assumed, I just divided by 30 days that it could be every day of the month. Yeah.
Yep, I was just looking at that one sheet that had the 261,000, but so 230 would be half of the total.
John, if I may, the grant agreement could provide that the hospital would pursue diligent efforts to obtain private donations, and that the amount of the grant, the unspent portion of the grant, would be reduced by any donations that are received. So that would be another way to do this.
I prefer that method, John, so the hospital can move forward with the confidence that they have full funding. And I think that we can entrust any commitment that Gary makes here that the hospital is going to go out and diligently raise funds from the private sector.
Gary, would that be a problem if we put that in the grant agreement?
I don't know how that would be a problem. If I reflect back on what I believe I heard, that would be if you funded, as an example, 460,000 to move both projects forward, and philanthropy rose that we would pursue through the Cottage Hospital rose 460, that balance would be returned to you. And then anything above that, we would continue moving with philanthropy to fund any additional growth of the study.
Right.
I heard that correctly. I hope that would be equitable to the community.
Yeah, we can certainly do it that way. It's up to the boards to decide.
Libby?
I thought Dawn's proposal was half of that total amount, number one. Number two, we did hear last night during the meeting that there is an active effort underway in the community to do fundraising. So that's just an FYI. I don't know that the burden has to be entirely on the hospital. I think there are community people out there who are really actively trying to fundraise for this.
So is the proposal select board? My question is to the select board. It's a proposal that you would ask the FinCom to authorize $230,000 from the reserve fund.
I'd like to hear from other board members. Christy and Matt.
I think if we go the approach where we're paid back, I would feel comfortable kind of putting that money forward so both projects could move. I think both are equally important for the community. And if there was a way for the town to be repaid, I think that is kind of fiscally responsible, and it shows our leadership in trying to get this started. If we did half of the study and then, trying to fund, I know they'd be trying to fundraise, but if it took a couple of weeks and that is delaying the start of the study, that would just be my concern.
Matt?
Yeah, I agree with Christy. I do it either way. I think, and again, I've pushed to have a committee because we have a lot of other issues. I'd have another committee outside of us doing some of the fundraising and some of the other things we need. And I think that they could be if we have the right doers and the right people on that committee, I think they'll raise this very quickly. But, short of that hasn't been approved, that isn't in place yet. I think Christie's suggestion is fine with me.
Brian?
Could I make a proposal that we consider funding the first half of it right now? Because we have to remember, we don't know what other expenses are going to come up between now and June 30th. And if we don't have a town meeting, the reserve fund might be one of the only ways that we have to close issues not related to COVID-19. If we don't need it before, John, correct me if I'm wrong, but we can allocate from the reserve fund through July 15th, correct?
Yes.
So if we didn't need it and the hospital was still short of money or needed additional funding, then we could come back and do a second allocation out of the reserve fund. But I'm entirely supportive of this, but we may have issues that we are not related to COVID-19 that we would need reserve fund money for potentially in the next month and a half. So I think if we were to do it that way, it's an indication of the town's support. If we did not need the reserve fund, we could call another meeting between now and July 15th, and the finance committee the select board could ask for the remaining reserve fund to fund additional money if the hospital still needed it. Would that work, Gary?
It would work, yes, from the standpoint of being able to get the PCR testing going. We won't be able to move forward with the serology piece until that's fully funded, is our guidance. So we would be looking towards philanthropy for that very heavily as well.
Jason? Sorry, Dawn. I
think we're hearing a couple different things here. I want to listening to John Giorgio, Brian, obviously, and then FinCom. I think putting something into it now, even if it's $50,000 in each one, just to show the towns that we're serious about it. I think that's the minimum we could do, or 100 in serology and 50 in PCR to get it going, or 50 in each, I think makes sense. And then what I'm hearing Brian say, we need 6 weeks, and then we can see what the fundraising options, what that can bring in. I think once people see the town put resources into this, then people will follow.
Be great.
So if we have the health director telling us that serology is his choice between the two, and we have Gary telling us that we can't move forward with serology until it's fully funded, I would suggest to the select board that you make the request to the finance committee to fund fully the serology study and leave PCR for other funds that become available.
Yeah.
Just to add in, sorry, Stephen, that sounds along the lines of what I was thinking. I hear the back and forth, and I hear what you're saying, Brian, but I think that would be approximately half. I think the wider spread PCR testing is also key, but I think if serology is what health department and Gary are on the same page about is a priority right now, then we go with that, and then look for looking for additional funds for the other testing as we go.
And if I can just add in, and I would agree with that, Rita, I would add in that once we know that we've secured a company that can do this testing, that can start right away just based on, I heard a suggestion from somebody saying, could a company come and get their employers tested? Well, yes, they could. And I would assume that they would pay for that testing. So that can get going. And the serology piece, I think, is key to fund so we can move that quickly.
Dawn?
And I would agree with that. I think we should fully fund the serology, and I think we should work on some outreach because I think employers would definitely jump to have all of their employees tested.
John?
So I have a question for Brian. Obviously, if you were to fund this entire both tests out of the reserve fund, you're not going to have much left for other emergencies. Brian, do you think you're going to have sufficient unexpended amounts in your operating budget where under Section 33B, the FinCom and the Board of Selectmen can vote to transfer line item amounts to meet deficiencies?
We typically always have. I mean, there's a couple of line items that typically have money. I mean, health insurance, we may have the ability to transfer it. I mean, we've had a lot of COVID-19 expenses, obviously, but we typically always make transfers at the end of the year. And I want to balance both needs to do this. So, I mean, if we funded the serology study, John, and that was the recommendation, that would still leave us just under 50% of the reserve fund, which again can be allocated through July 15th if we did have if everything came together the way we think it was going to be. So there would still be an opportunity to be able to contribute if the board and the FinCom agreed to do it, to be able to do it.
Thank you.
Matt?
I'm fine with the serology full, but I think we need to put at least 50 or 100,000 into the PCR study. That's time sensitive. It's how we will. I just think it's crucial, and I don't think we should wait a week or 2 weeks to get out in the community and start doing that. I think we need to do that yesterday. So I don't want to see that wait.
Christy?
Yeah, I agree with Matt. I think if we could put something like 25,000 or 50,000 towards the PCR testing to at least kind of kickstart that campaign, and it could help kind of lead to other donations. And then if it's possible to still have that caveat where if they fundraise the money, the town would be paid back.
I would support that.
So it's Thursday afternoon. We're going to need a grant agreement to go forward with any of this. What's the realistic timeline for that? I mean, do we have the weekend to try to go out and secure some private funding to maybe earmark that for the PCR?
Well, we wouldn't want to disperse any funds without the grant agreement in place. So we'll have to get cracking on drafting that grant agreement. When, Gary, do you need the first dollar?
Well, if we,
I'm sorry. When do you need to secure the 261,000 for the serology testing?
I have to have a commitment that's been funded before I can begin the study.
Right. And when did you want to start the study?
As soon as possible.
Gary, is a vote today that's approved by FinCom a sufficient commitment to get started, and then the signed grant document beginning of next week to follow?
I believe that would meet the test.
Okay.
Yes, if the FinCom votes, we can certainly start dispersing the funds subject to the grant agreement. Right, Brian?
Sure.
It's fine.
Well, let's not get carried away, John. It's
Well, I do have a long weekend coming up, so we can certainly bang out a grant agreement.
Thank you.
I'd also add that if on the PCR test, that if you in your proposal include dollars for that, that this vote that you take would be give us the confidence that we need to begin ordering that, so that we could, once received, start providing that.
So just math, folks. $25,000 at $150 a test is 166 tests. And then obviously double that. So 332 is $50,000 on PCR, just to give the select board some numbers to think about. So you're either looking at, now I got to do math in my head. So you're either looking at 286,800 is at the $25,000 level for PCR. And then 316,800 is the level for 50,000. So the 300 and something tests, which is about a third of the number of tests that are interested to be done or intended to be done. At 316,000 though is now 60% of the reserve fund. And we were a few minutes ago at a little over 50% of the reserve fund. So just to keep that in mind. And to Brian's point, I'm wondering if the more reasonable, or not the more reasonable, but a little bit more cautious is to say fully fund serology at 261,800, add 25,000 to get started on the PCR. And then by the middle of July, as Brian said, as we see things develop, then we could add additional money to the PCR. Or is there an appetite to go from the select board to go further on the PCR at this point?
I would vote for the more conservative approach.
Thank you, Dawn. Peter McKeechern?
A question for Roberto. Roberto, with surveillance testing, does random PCR testing help?
Yes, absolutely. Random testing is always really good.
Matt?
Yeah, I motioned 3:30 last night. I'm happy at 3:15 or 3:16. I think we need to, show the potential donors how, we support this and how important it is. If we write the grant up, that the money can come back to the town. If it's a successful ask, then if we can get 100, 150, 200 of that back, the more we get back, the better. If we fundraise it, I think we could do both things. I think we could, get the money they need now and get them started, and then put in place the fundraising to return, a good amount of this back to the town.
Thank you. Jason?
This is for what Matt's saying. And what does this group think of if we commit to the 316? Do we think people are going to underwrite money to come back to the town? If we've already paid for it, we're good, right? We seriously think that could happen?
Depends how the grant is written. I mean, it depends how the document's written. If we're fronting the money and it's understood that some of it is coming back because we're struggling to front it, it depends on how good a lawyer John Giorgio is, right, John?
Nothing to worry about there, Matt.
Brian, are you comfortable with the 316 number based on what we've talked about on this call?
We'll make it work.
Okay. Peter McKeechern just did a thumbs up. So,
I'm sorry, this is Erica. Where is the 316 number coming from? 261,800 plus, I'm assuming 50,000 is 311,800.
Yeah, I was doing math in my head here, Erica. So that wasn't good. So yeah, I was given a little 5,000 extra that nobody noticed. Yep, it's 311.
I just want to make sure for the minutes.
No, I was doing that one in my head. So look how well that worked. All the other ones I've been doing on a calculator. So there goes my elementary education right out the window. Okay, thank you, Erica, for the clarification. So select board, it's over to you to make a request, as I understand from John.
Does someone want to make a motion for a request for 311,800?
I would, so moved.
Your second?
Second.
All those in favor by roll call? Jason Bridges?
Aye.
Matt Fee?
Aye.
Rita Higgins?
Aye.
Christy Ferrantella?
Aye.
I am actually not in agreement, so you have a 4-1 vote.
And I'm sorry, John, should the motion mention this is pursuant to a grant agreement? Or
I think you can add in to direct the finance director and town council to prepare.
Or is that more the FinCom vote?
No, I think that should be part of the selectmen's vote.
Okay. Is that okay, Rita?
Yeah, and accept that as an amendment.
Does anyone have a concern with that?
Okay. All right, thank you, Dawn. So FinCom, further discussion on the proposal in front of us, which is to allocate $311,800 from the reserve fund to fund the hospital's serology program at $261,800 and add $50,000 to fund the PCR testing. With the caveat that it will be a grant proposal that explicitly states that any money raised in excess of what they need for these two programs will be then refunded to the town. Further discussion from the FinCom members before we take a vote on this?
Yeah, I'd like some clarification on exactly what the grant's going to say. So $200,000, I think, was somewhat of an arbitrary number for the PCR because, that number could go, the sky's the limit really on that, depending on how many tests you want. So are we saying that it's the 231,800 plus 200,000 for PCR? So everything above that 460, I think it is now 460.
261,800, yeah.
So is it everything above that amount of money that's raised would then come back to the town up until we're fully repaid, or do we want to be half repaid? What are we asking here?
I thought it was 261,800 to fully fund the serology and 50,000 seed money for PCR.
That much I'm clear on, but okay. As far as the money coming back to the town, how much does the hospital need to receive in donations before we receive any of the money back? And are we asking to be fully repaid if that's what the private sector, gives?
John?
So the way I was thinking of drafting this is in the grant agreement, we would require that the hospital fund these studies with the oversight and protocols established by the Board of Health, number one.
Okay.
Number two, the hospital would commit to using diligent efforts to fundraise, and that any private contributions that are raised will be paid back to the town up to the total amount of the grant, unless the board wants to make a permanent commitment of a contribution by the town. It would say that the total grant is $311,800,000, which will fully fund the serology test and provide seed money of $50,000 for the PCR testing, and that the hospital, if circumstances warranted, could request additional seed money or, additional funds to complete the PCR test.
Okay, so.
But that's up to you. That's a policy question. Do you want to only require a portion of the grant funds to be returned to the town based upon private donations?
So I share the optimism that there's going to be a groundswell of private support, and we will be able to, raise a lot of money here. But if we're asking for the town to be fully repaid before we can add another dollar to the PCR program, I don't know how many weeks we're talking about delaying adding additional tests.
No, I would not write it that way, Stephen. I would write it that we're making this grant now, and it's $311,800 1,800, and that to the extent that if fundraising is sufficient to raise that entire amount, it will be paid back to the town. If the hospital needs further funding to complete either of the tests, really, because I suppose there could be an unknown expense, then they're certainly free to come back and request additional funding. And as Brian said, the town could do a reserve fund transfer up to July 15th. I don't even think we have to put that in the grant agreement, though, because after that, there might be other circumstances where the town can provide funding outside of the reserve fund. Does that make sense?
It may make sense to everybody else because nobody has the same question, but I'm wondering when PCR program gets added to.
I think that needs to be something discussed at another time.
I'd prefer to do it now while we're talking about entering into a grant agreement.
Well, so I'm sorry, John. My understanding would be, because we're now, if I do, let's just say we're $150,000 short from their original ask, because I can't do the math in my head right this second. So the hospital will go out and fundraise for the 150 shortfall, and then they will amazingly get $750,000 contributed in total, because it's just, people are generous. So first they'll fund the shortfall of the PCR with their donations, and then anything in excess of that then starts coming back to the town until they have repaid the $311,800. That would be my understanding of the process, but I could also just be wrong.
I would like to say that so far I'm concerned about something that hasn't been mentioned, which is the size of the population increase, and no one has yet spoken to that issue insofar as the threat we face from the influx of people arriving for this season.
Matt, you had your hand up?
Well, I call that the churn, George, and I talk about it every week. And I think it's real, but that's for another time. I don't think we need all of it back. I think we can leave, like John said, half of it, or leave, a couple 100,000 of it. And I don't think we need it all back. This is an investment in our community. This is an investment, especially the PCR. This is an investment in, sort of keeping us from having that outbreak. And so, I don't think that we need to try to get every penny back.
Yeah, I'm thinking along those same lines. I mean, and I also think that we might not need every, and Brian, maybe you want to correct me here, but maybe we don't need 100% of the first dollars that are raised. Maybe we want 50 cents from every dollar that's raised up until we get paid back to whatever level we want to be paid back. And that allows the PCR fund to grow more quickly.
Again, I'm sorry. I have to. Sorry, Jill. I'll call on you next. So we give them. I'm going to go to round numbers. We give them 300. They need 500. They then go out and raise 200. We get none of that back. Then after 200, so now they have the 500 in total that they needed. 300 from the town, 200 from donors. At $500,001, we get that one. So what you're suggesting, Stephen, so the first fundraising, we don't see any of it until they reach their total amount that they need at this moment. What of the two numbers that we've just discussed? And then starting at 500,000, let's just go to 600,000. So the next 100,000, we get 50 of it, and the hospital gets to keep 50 of it for further stuff, or that's when the 100,000 comes back to us. Sorry to be so pedantic, but I think John needs to know this to write the grant agreement.
Yeah, and I realize we need to move towards resolution, so I'm fine with either one of those things, really. I just think the 200,000 for PCR, is a number that was, it was just a number.
that right. Number could have easily been 250 or 500,000. But if we want to look at it like that's a hard number, and all the money goes to filling that original ask first, and then some money starts coming back, I'm comfortable with that.
I think that's the most practical, but that's just my personal point of view. Jill, you had your hand up.
Yes, I wanted to know from, maybe Matt wants to answer this. If we do a serology test now, then, and it shows our summer population, depending on the outcome of that, maybe it's low, maybe it's a little higher, are you going to want to do this study again in the fall because our population looks so different?
Well, I'm not sure I'm qualified to answer that. I'd like to have a committee that's together with, helping Roberto, helping the hospital with specialists that know this stuff. I've learned, I know enough just to be dangerous right now, but I think that they, we need people that will advise us in the fall based on that situation, based on what we face in the fall. I think it would be really helpful now if we know in 6 months from now that we've got 5%, then we know that we're at a ton of risk. If we have 20 or 30%, like a couple of the communities potentially do, near Boston, then we're in less risk and we can open up a little more. And so I just think that it's part of what the Board of Health needs to make the policy decisions, to make some of these choices that right now we're making, based on sort of, we did a really good job at the beginning, and now we're, sort of closing it like we did, and we've kept the island in a really good state. But I think, I'm getting texts now as we're sitting here, the boats are full and the people are coming, and, and 50% of them or more are coming from the hot spots. There's going to be a lot less distancing, and I watch all the customers coming up every day without masks. We're in a precarious situation. We're entering a very precarious situation right now. And I think that knowing our baseline and seeing how quickly that goes up will give us a lot of information.
And I appreciate what you're saying, and I know it's important. I guess my point is, I don't think we're going to see this money come back, and I just want to have an honest conversation about that, because I feel like the testing will have to continue for a long time.
I think written, yeah, and you're right. And I think written how it is, if we're fundraising and 50% of the dollars after 600, like Denise just said, then I think we would get, the town would end up with, say, 200,000 in, and the rest would come back, and the donors would keep funding, so we could test through next year if it's necessary. If we're going to do monitoring and surveillance and that type of approach, if we start to have, it's cheaper to do, at least from what I've read, it's cheaper and better to get in front of it and do it now than to get into the medium or strong breakout. If you're in that situation, you need a lot more contact tracing, a lot more employees, and a lot more testing. If we can be in front of it now, I think that it's cheaper and it's more effective and it's better for the economy and better for the health. So I just think, that's why I think the PCR is so important.
And the virology test, or the serology test, does run through November. It's 6 months, Jill. So it will be in November, December. Do we need to look at it again? Right, Gary?
I agree. Denise?
Okay. John?
So I had two questions from the grant writer standpoint. Gary, would you have a problem if we required a monthly accounting of expenditures from the grant?
Not at all.
Okay, so I'll put that in. And then in terms of Denise's, she was going exactly where I was going. So the first 150,000 fundraised, the hospital would keep and pay for the rest of the test, the PCR test. Any amounts fundraised over that, I heard two things. Either we only get reimbursed 50% of that up to presumably, well, so that would mean we would, I guess the question is, of the 311, is the town willing to commit a portion of that as a town cost and not require reimbursement? I heard that concept floated. I just didn't hear a resolution.
I heard that too, John. So I think it's back to the select board to say we will seek forgiveness of the 311,800 that we're donating. We will ask you to refund us 100,000 or 150,000, and beyond that, it's the town's donation to getting this done, to taking care of our community, or whatever number the select board is comfortable with. But I think that has to come from start with the select board and then be a resolution for the FinCom as part of the signing off the whole thing.
Was there a proposal from the board on how much they'd like to not have given back?
I'll start with 50%. I'm fine with that.
Anybody else? Okay.
I'm okay with that.
That's fine with me.
Is that a motion?
Yes.
Second.
All those in favor by roll call: Jason Bridges.
Aye.
Matt Fee.
Aye.
Christy Ferrantella.
Aye.
Rita Higgins.
Aye.
John Holgate, aye.
Thank you, Select Board. Okay, so here we are, FinCom. The resolution is to, or the proposal in front of us is to fund $311,800 from the reserve fund, to allocate the funds from the reserve fund to support the request from the Nantucket Cottage Hospital, fully funding the serology study, partially funding the KPR. It will be based on a grant, which is being written by John. Giorgio will write the grant with the points that he raised before. And the other salient point that we are considering is the fact that we will ask for reimbursement up to $155,900 of the money that we donated. So that's the proposal in front of us. Just to summarize, and John, I'd like to add in one, and I see Libby, you're raising your hand. I'm going to call on you in a second. Oh no, you're just waving at me because you are missing me desperately. I like that. He's writing. So Libby misses me a lot. That's what I tell myself every day. I would like to, John, potentially, and Gary, it's only because of my institutional knowledge, potentially we could put a phrase in that the NCH has continually, it's back to Peter Schaefer's earlier point, has been able to get PCR testing at a more effective cost rate. You know, it is something that's reviewed once a month and talk to suppliers. And I know it's based on what supply is available where, you know, as to whether Quest or whoever the diagnostic companies can get from their suppliers the actual tests. I understand how all that works. See that rigorous, because the cheaper the test, the more we can test. So I would love to see that as one of the elements of the grant. Not to say that we would question it, but we would like to see that you're able to do that. If that's, does that make sense?
It makes sense, but it's not something we can do. The reality is, regardless of what vendor has the supply, whatever negotiated cost per test there is, the partner's price for that is $150. I can't change that. So that would have to continue. Okay, so Partners doesn't go out every month and renegotiate this or take a look at this with the. So you're saying that you have the Partners price, period. There's not. I mean, obviously, I understand you're part of the bigger company, and they do all the procurement related for your hospital. So that's correct. And Partners is interesting. Okay. That's sad because I would have liked to have seen that. So, okay. So, any other comments from FinCom before we vote on this? I don't see any hands up. George, I can't see you, so I don't know if you have a hand up. I assume you'll just jump in. Okay, so that somebody besides me has to actually make that motion, and somebody else has to second it.
So moved.
Thank you, George. Okay, seconded by Stephen, and by roll call, as I can see you on the screen. So Jill Veith.
Aye.
Thank you. Peter McEachern?
Aye.
Okay, I'm looking. Stephen Morey?
Aye.
Peter Schaefer? You have to unmute Peter Schaefer.
No.
Okay. So George Harrington?
Aye.
Okay. And Denise Cronow, aye. Okay. So it's passed. Jason Bridges? Jason?
Yeah, I'd just like to either, I might need a motion for this. I don't know. I would like to have in this grant written in there that the town of Nantucket, whether that's the Board of Health, has access to all this data, because MGH owns this data. We have to have access to it. So if they can't get that from whoever, it's our hospital or MGH, then I don't think we should go forward with it, because we need the data is kind of the whole point of it.
Gary, do you have a comment on that?
I'm not sure I understood the question. The data related to PCR testing and what the number of tests are and that type of information but we can certainly share what the expenses and how many tests are done. The public health department has the data that comes back. It has to make a decision with the Board of Health on what's shareable. I don't control that. Related to the study, unless you're listed on the study as an individual, the data that comes out of the study is a report of the results. But we don't share the actual data set with any other entity. There's none listed on the set. That would assume that somebody else would be doing research on it, and that's quite not going to be allowed. So the study stands as its own. So I don't know if I answered your question that way.
But it will be provided to the Board of Health, correct? The results of the study?
Absolutely.
And what about the individual data sheets, I guess is what I would call it?
Individuals are de-identified, so there's not data going back to individuals. That's a part of the study, right, so that we understand that we have prevalence in a community, but it's not identified by individual.
But will Roberto have access to the data that was developed as part of the study?
Yes.
John is asking about the raw data.
No.
Let's see. I have to look at the study. I believe Roberto is listed on the study. But if he's listed on the study, then yes, the idea would be that the public health department would be able to obtain this data for sure.
Yeah, I believe I was on that proposal.
And Roberto, when you put together the protocol, you should include that. I'm going to include it in the grant agreement as well.
Thank you.
Sounds good.
Okay, everyone. Libby, anything else from your side that needs to be accomplished at this meeting today?
I don't think so. Thank you.
Thank you. Dawn, anything else? I mean, I'll make a motion to adjourn FinCom, and then you can make a motion to adjourn Select Board. So motion to, even though I keep doing this. Somebody want to make a motion to adjourn?
Yeah, motion to adjourn.
Second.
Second, is there a second? Thank you. All in favor by roll call. Jill Veith.
Aye.
Jill Veith, motion to adjourn.
Yes.
Thank you. Peter McEachern.
Aye.
Thank you. Stephen Morey.
Aye.
Peter Schaefer.
Aye.
George Harrington.
Aye.
Denise Cronow. Aye. Over to you, Dawn. Thank you.
Can I have a motion to adjourn? There's no other business.
So moved.
Thank you. By roll call, Jason Bridges, Matt Fee,
Aye.
Christy Ferrantella.
Aye.
Rita, I don't know if you're still there. Rita again.